Hello everyone. Today we'll discuss about upper limb injuries. This is the part 1. Part 2 will be discussed on the next day. To begin with, upper limb includes clavicle, scapula, shoulder joint, humerus, elbow joint, forearm bones, wrist and hand. Today we'll discuss in the part 1 about clavicle, scapula, shoulder joint, humerus. As you know, shoulder joint includes glenohumeral joint, which is a synovial joint, and the scapulothoracic joint. There is also another joint, acromioclavicular joint. You can see how these bones articulate in the shoulder joint in this video. There is the glenohumeral joint, there is the scapulothoracic joint, and there is acromioclavicular joint. You can see some ligaments running from humerus to glenoid, some ligaments running from coracoid process to clavicle, which are called coracoclavicular ligaments, and there is a ligament which is called acromioclavicular ligament running from acromion to clavicle. Most of the injuries in the upper limb are indirect. The method mainly described as a fall on outstretched hand. Depending on the position, it may be flexed or extended arm, so that will cause corresponding deformity. So first we'll discuss about the dislocation and subluxation of the sternoclavicular joint. As you can see in this X-ray, there is a normal articulation between the medial end of the clavicle and the sternum. On the opposite side, you can see clearly the medial end of the clavicle separately, and there is the articular surface of the sternum. So as you can very well see, there is a subluxation, but often the diagnosis is missed in the X-ray, but it is easily made in the clinical scenario, as there is a very distinct type of deformity, a bony projection in just below the neck in this area. So when you get a patient with sternoclavicular dislocation, it's often painful. It may be reduced by direct pressure on the clavicle, but the recurrence is very common. But for some reason it never causes much morbidity. It's very well acceptable by the patient unless it is cosmetic problem. Next we'll discuss about a very common fracture, that is the fracture of the clavicle. Some of you already have faced it probably. It's common in all the age groups including children. The commonest side is between the middle and the lateral third. As you can see, this is a typical case of clavicle fracture. This is the middle third, and this is the lateral 1/3. This is the typical deformity. Projecting underneath the skin is the medial end of the medial fragment, the lateral end of the medial fragment. This fragment is pulled upwards by sternocleidomastoid, and this lateral fragment is pulled downwards by pectoralis group of muscles, causing this typical deformity. But often there is fracture at the lateral end of the clavicle. You have to be careful about diagnosing this kind of injury. So the most of the time this is treated conservatively by an arm sling and a figure of 8 bandage. Of nowadays clavicular brace is ready-made. It is available in the everywhere, but when you apply a figure of 8 bandage, this is a figure of 8 bandage, you have to pull the bandage backwards so as to extend the shoulder maximally. This will cause reduction of the fracture displacement, and then we have to keep an arm pouch bag or a collar and cuff sling for 4 to 5 weeks. with gradual mobilization. But sometimes operative fixation is needed, especially in case of open fracture with those with neurovascular injury or non-union, or there is a cosmetically unacceptable deformity by the fracture. So, mostly this is operated by plate fixation. Often we treat it by an intramedullary nail, and in case of lateral end clavicular fracture, we treat it by this kind of lateral end anatomical plate. Next, our topic is the dislocation of the acromioclavicular joint. As you can see in this X-ray, this is a normal AC joint. In this picture, you can see there is a displacement at the acromioclavicular joint. Often this is, if you see the shoulder of the patient, this is the normal contour of the patient. There is a typical step as the lateral end of the clavicle projects underneath the skin. It is often missed, especially the early grades are missed in the X-ray. If you do a stress view X-ray, that is, if you suspend weights on both the upper limbs, then the occult AC joint subluxation may become more prominent, and you can diagnose it easily. According to Rockwood classification, there are 6 classifications. There are 6 grades actually for this AC joint dislocation. In type 1, there is a mild sprain of the AC ligament. This is the AC ligament, mild sprain. It's not torn. In type 2, the AC ligament is torn, but the coracoclavicular ligaments are intact. So in these two types, there is not much displacement in the lateral end of the clavicle. So these are treated mostly conservatively with collar and cuff sling for 3 to 4 weeks, then early mobilization. But in type 3, this coracoclavicular ligament, which are the main stabilizer of the clavicle, are torn. So the clavicle is displaced. In type 3, it is displaced slightly upwards. In type 4, it is displaced posteriorly. It is in type 5, along with these ligaments, all the muscular attachments are torn. So the clavicle is displaced upwards and almost projecting out from the screen. And type 6 is a rare variety when the clavicle dislocates anteriorly and comes underneath the coracoid process and the conjoint tendon. So all these 3, 4, 5, 6 type needs surgical intervention. So how do we operate? We just we fix the dislocation with a K-wire or a plate or some other methods. Then we reconstruct these ligaments, torn ligaments, by taking autologous tendon grafts from semitendinous muscle or some other muscles, gracilis, etc., to provide a biological stability. Okay. Our next topic is fracture of the scapula. It's not very common, but when it's associated, it is generally associated with a high velocity injury. Always be careful about diagnosing a scapular fracture because it is usually associated with some chest injury or other life threatening injuries. So mostly conservative, but sometimes it needs operation. As you can see, when there is a displaced intra-articular fracture, this is the glenoid which is just fractured and displaced. It needs fixation. As you can see, this screw has fixed the glenoid. And when there is altered glenopolar angle is the angle when you draw a line from upper end of the glenoid to the lower end of the glenoid, and from upper end of the glenoid to the lower end of the scapular body. This angle is glenopolar angle. It is usually 30 to 45 degree, but when it becomes less than 30 degree, it requires surgical intervention, which is done by this kind of plate fixation. Next we come to a very common topic, dislocation of the shoulder. You must have seen if you have gone to emergency of any hospital, it's very common, and most of the dislocations are anterior dislocations, but sometimes there is posterior dislocation, which is generally associated with convulsions, which may be epileptic or electric shock. Inferior subluxation are very rare, which are called luxatio erecta. Habitual dislocations are seen in mostly the ligamentous generalized in patients with generalized ligamentous laxity, and these are painless, non-traumatic, and multidirectional, and this does not require any treatment. So mostly the anterior dislocation is classified in three types. As you can see, this is the normal joint. The humeral head has dislocated towards medial side. So we classify this according to the position of the humeral head. When it first comes in front of the glenoid, it is called preglenoid. Then it comes just below the coracoid, that is subcoracoid, and then it crosses the coracoid process and lies underneath the clavicle, that is infraclavicular. So this subcoracoid variety is the most common type of anterior shoulder dislocation. The mechanism of injury is mostly indirect, with fall on abducted and extended shoulder, or there may be a direct blow to the shoulder. As you can see, the capsule, this is the capsule, and this is the hole in the capsule, from where the humeral head has come out. This is the torn part of the capsule and the rotator cuff sleeve. And there is an inferior component, that is the humeral head has subluxated not only anterior but it's anterior inferiorly. This is a typical posture. There the patient is in severe pain. It's holding the hand steadily with abducted. The patient cannot bring the arm to near the body. There is this loss of contour. If you can palpate in this area, there is a halo, there is a gap underneath the acromion bone. Often you can find the humeral head lying in this area. You can feel a globular bulge which moves along with the movement of the arm. You can see there, this is a typical deformity in the shoulder dislocation. So you have to cautious about shoulder dislocations because it may be associated with neurovascular bundle injury or associated fractures and axillary nerve injury. So axillary nerve runs just beneath the surgical neck of the humerus in this fashion. So it is very it may be stretched by the humeral head. You can find a patch of anesthesia, patch of loss of sensation in this area when axillary nerve is injured. If in axillary nerve injury there is loss of contraction of the deltoid muscle, but it is not possible to identify in acute settings, but the loss of sensation you can always identify. So how do you manage anterior shoulder dislocation? It's always an emergency, as you know. This has to be reduced within 24 hours. Otherwise, there is fear of avascular necrosis of the humeral head. But before any attempt at this correction of the dislocation, you have to check for is there any neurovascular deficit. So there are some methods described in the literature. This is Hippocrates method. As you can see, this is not performed nowadays. This is only of historical significance. This is also of historical significance, the Stimson's method. This is also not performed, In this method, the weight is suspended from the arm for long period, and the shoulder shoulder dislocation is corrected automatically. The method we commonly do is Cocker's method. It's generally under general anesthesia or some sedation. We give gentle traction to the shoulder. We gradually externally rotate the shoulder, then gradually bring the arm near the midline of the body. Then we external rotate it. This is the method of connection. There are some other methods where we bring the arm to 0-degree abduction or 180-degree abduction and push the head inside the glenoid cavity. So, as we already discussed, there are some complications of anterior shoulder dislocations, including early complications such as neurovascular injury, axillary nerve injury, or associated fractures. As you can see, there is a greater tuberosity fracture, but more commonly these type of fractures are automatically corrected after the dislocation is corrected. As you can see, the GT is sitting almost at the normal position after correction of the dislocation, but often this GT does not come to its normal position. Then this has to be operated and fixed with screws. There are some late complications such as avascular necrosis, heterotrophic calcification, but most commonly the late complication is recurrent dislocation. There are some pathology associated with recurrent shoulder dislocation. You may have heard about the terms Bankart lesion and Hill-Sachs lesion. So, what are these? The Bankart lesion is a lesion situated in the antero-inferior part of the labrum. As you can see, there is the labrum here is detached from the glenoid, producing the Bankart lesion. In the axial cut of the MRI, you can see this labrum is torn apart from the proper glenoid. And in this picture, you can see when the humerus, the head of the humerus dislocates anteriorly, the posterior superior aspect of the humeral head impinges on the anterior part of the glenoid labrum. When there are multiple times dislocation, there is a large cavity created on the posterior superior part of the head of the humerus. In the axial cut of MRI, you can also see this. This is called the Hill-Sachs lesion. So, recurrent shoulder dislocation is often well tolerated by low demand patients, but for high demand or young patients, there are some surgical procedures performed such as putty plate, Bankart's, Bristow's repair, and for Hill-Sachs lesion, this is treated by Remplissage procedures. So, most of these are done arthroscopically nowadays. Let me come back to the previous slide. Let me clear these signs. So, how do we what we do in the operation? We enter the joints by arthroscopically by camera and cannulas. So, what we do, we repair this labrum to the bone to the glenoid. We insert some anchors here. Anchors are these kind of screw-like structures, small screw-like structures with attached suture. So, we put 2 screws in the glenoid and we tie knots along with the labrum here, and in Remplissage procedure we put anchors in the humeral head and tie knots with the infraspinatus and teres minor muscles, which obliterates the Hill-Sachs lesion. So, next we come to the fracture of the humerus, which may be proximal humerus, shaft of the humerus and distal humerus. So, we will discuss only about the proximal humerus fracture and the shaft of the humerus fracture today. The proximal humerus fracture is common in elderly women, but occur at any age including the children. Neer has classified is based on the parts involved. In this X-ray, as you can see, there is fracture of the humerus. So, there are some fragments. That is, the number 1 fragment is GT, number 2 is head, and number 3 is shaft. So, this is a 3-part fracture. If there would be another fracture, such as in the LT, including the LT, this would cause the 4-part fracture. So, you can see, according to the parts in the fracture has produced, the terminology changes. So, in elderly women and in low demand patients we treat this by closed reduction and the K-wire fixation. Elderly and some children, we can also fix this by K-wire fixation, like shown in this picture. But in high demand patients, when early mobilization is required, then we fix it by this kind of plates. These are called Philo's plates. So, as you can see, the fracture, the plate is fixed to the humeral head and shaft by screws. These are locking screws. These locks to the plate, and there you can also see some small holes in these areas. These are actually not for screws, these are for sutures. What we do in very comminuted fractures, we tie these holes with the muscles, with the rotator cuffs. There is supraspinatus, there is infraspinatus and teres minor, and in front there is subscapularis. So, we tie sutures to these muscles and tie these sutures to the plate with the help of these holes, so as to produce a sac like structure which is fixed with the plate. It will help in early mobilization of the patient. So, next we come to the fracture shaft of the humerus. It is mostly indirect, but may be direct, and there is often associated with radial nerve injury. Its management, diagnosis is very easy, but the management is quite dicey. Actually, the decision is taking is very difficult in these cases. Most of the time, closed reduction is successful. It is done by U-shaped slab or a hanging cast. This is a U-shaped slab, as you can see, U slab, or this is the hanging cast. Hanging cast, the principle of hanging cast is that the reduction is maintained with the help of the gravity. That's why it is called hanging cast. A few weeks later, when the initial stability of the fracture is achieved, we apply a functional brace. This is the functional brace. Then give mobilization to the shoulder and elbow. Some indications are there for open reduction and internal fixation fractures, such as failure to reduce properly or bilateral humeral fracture, open fractures with radial nerve injury, unconscious patients, and when there is delayed union, non-union or malunion. So, we do it mainly by 2 methods. One is by plate and screw methods. As you can see, the fracture is well united, and we may do it by intramedullary fixation. This is called tense fixation. This is titanium elastic nailing system. We enter the humerus from distal aspect and reduce the fracture by closed method without opening the fracture site and fix it, and this is called interlocking nail of the humerus. As you can see, we enter the humerus from proximal side, from the humeral head, and fix the nail with the shaft by interlocking screws. These are interlocking screws or locking bolts. So, we have to discuss about radial nerve injury when we discuss about humerus shaft fracture. So, as you know, radial nerve injury causes wrist drop. It is associated with up to 12% fractures of the humerus. Mostly these are neuropraxia, but their nerve lacerations are also common. You can see in this picture the radial nerve runs close to the humerus body, to the shaft of the humerus along the spiral groove. And spiral groove. There is stretching of the radial nerve when this kind of fracture occurs here. Also, the nerve may be injured during the plating procedure. There is a specific type of radial nerve injury which is called Helston-Lewis fracture, when the radial nerve is entrapped between two fracture fragments. So this is intra pictures. You can see this is intact radial nerve running above the plate, and this here you can see lacerated radial nerve injury. So how do we manage radial nerve injury? When we have to explore the radial nerve immediately when there is open fracture, and then we will have to try to repair it. But in case of closed injuries, we do not require to explore the radial nerve immediately. What we do is we observe the progress of the radial nerve injury by by doing nerve conduction studies or electromyography at frequent intervals and awaiting a spontaneous recovery. So we generally wait up to 12 weeks. If there is no progression or no improvement of the radial nerve function by NCS or EMG, we go for exploration of the nerve. In non-salvageable cases, when the nerve cannot be repaired, we do Jones transfer. These are mostly done by plastic surgeons, but you have to know the principle. Here the main principle is here we have to use the median and ulnar nerve to produce the functions created by radial nerve. We transfer the muscles supplied by ulnar and median nerve to the muscles supplied by radial nerve. As you can see, in Jones transfer, the pronator teres is transferred. Pronator teres is transferred to extensor carpi radialis brevis. So pronator teres contraction will produce extension of the wrist. FDR, FCU and FDS can be transferred to extensor digitorum. This will cause extension of the finger. And FDS palmaris longus can be transferred to extensor pollicis longus. This will solve the problem of extension of the thumb. So this is how a non-salvageable radial nerve is treated by muscle transfer. Okay, so this is the end of the lecture for today. We will discuss about the rest of the upper limb injuries in the next class. So if you have any questions, please inform me.